Well, good afternoon. It's a great honor for us to be here, and thank you for Sage's board, and especially thank you for Patricia Silla, who support my work since we met. We come, here my disclosure. We come from France, a very long trip, and there is a special smile about history between Baltimore and France, because we are coming from an harbor in the northwest of France, which is called Le Havre. And after World War II, most of the leadership supply who come in France to rebuild Europe start in Baltimore. So it's a smile of history. But we are not here to speak about history. We are here to speak about surgery, and especially scheduled colectomy. For years and years, we learn, soaked, and teach that this picture shows the safest place in the world. But we have to change our mindset. Why? First, because when you are in a hospital bed with an IV line, you don't move. Second, I don't know how is your hospital food, but in France, hospital food is quite awful. And third, and which is the most important, when you are in a hospital, you are under a pressure of an ecological germ system, which is very dangerous for a patient, especially for his microbiome. So, patients need to be at home, because at home, they move, they feed whatever they want, and they are in their own ecological system, and it's quite better for their bowel function. On first hand, we have ERAS, and I must insist, ERAS is a complete protocol. There is 21 items, and you don't have to choose one or two items. You have to applicate all of them. And now it's evidence-based medicine that if you applicate ERAS, you have a decrease of mortality, morbidity, and hospital stay. On the other hand, from another side of the surgery, you have ambulatory surgery. And in France, we have a different definition. In France, ambulatory surgery means the patient must stay less than 12 hours in the hospital. So the patient must be discharged the same days after surgery. We have with ambulatory surgery exactly the same benefits than with ERAS, but in addition, we have a less loss of function, especially in elderly patients, and we have a costless and hospital profit margin, which is increased. If you mix ERAS and ambulatory setting, you have this conclusion: the patient is ambulatory, not the surgery. If I have to say that with other words, I say that ambulatory is one side of ERAS. Here, our experience, about 4 years, 162 patients, most of them are left colectomy because I wait to manage perfectly intracorporeal anastomosis before starting right colectomy. There are 3 total colectomy and 4 reversal, heart-mount reversal. 1/3 of our patients are other 3. So there is no selection. There is contraindication, but no selection out of the contraindication. We have no mortality. About 162 patients, 8 patients discharged after POD1 to POD7. It's a fail of ambulatory setting, but it's a success of ERAS program. They are eventless. 164 patients discharged the same days after surgery. 134 have no problem. 13 patients need unscheduled visits. 10 because they feel anxious, they don't take correctly that painkiller, or there any small problem. No problem after. 10 have one problem, infection or anything like that. But they only need nurse care at home. 10 patients need readmission in the hospital. 3 only for observation, 1 because of a pneumonia, and 6 need re-operation. 4 for leaks, 1 for epiploic necrosis. It was an obese patient 2 weeks after a total colectomy, and 1 for hernia repair. We have no mortality. How we do that? Everything is during the first visit with the patient and his relatives and his family. I must explain the pathology, the surgery, the risk, the complication, how to manage the complication, all the best way, and to educate the patient. I give them a booklet and 2 little movies on a USB key. So I build a bubble of security around the patient. After they are registered on our data, on our MyLab project, and I explain after. And during the day of surgery, we only use ERAS recommendation, no more, no less. And after, we build a follow-up. The key role of the follow-up. When we start, we have a homemade follow-up with, during 21 days, we start with home nurses twice a day during 6 days, and after once a day for thromboembolic prevention. We have blood sample as recommended in France, and personal phone call each day for data collection. Of course, 24-hour hotline with my team, and an emergency link. And I scheduled a visit at POD 6 and POD 21. But it was a very, very heavy protocol for my team. So now we switch with a data collection, digital option with a startup, which is called Myla in France. And Myla provides us a link, digital link between the patient and the team. So I build an algorithm with the item I want, and they provide us a connection with the item between the patient and the team. And I have some alert, and I have something is normal, and I have some guideline for the patient, which is directly exchanged with the patient by SMS or email. And Myla provide more a 24-hour nurse hotline. Of course, we still have home nurses twice a day during 6 days and once a day after. Blood samples are exactly the same. And I maintain emergency link, but I have only 1 scheduled visit after. How to managing the risk? I want you to focus on this picture. Who wants to travel the desert on this truck? I think a majority of you said no. We have to do exactly the same now in surgery. Not waiting complication, crossing finger, but anticipating the complication. About the risk. The bleeding risk is now very rare. If there is nothing during surgery, it's exceptional to have anything after. We have instruction on our booklet and a home visit when patient return home. Anastomotic leak, it's the fear of the surgeon. It's incidence about 4%, but maximum occurrence, it's POD 10 to POD 12. And if you apply ERAS program, you discharge for a patient without follow-up before the maximum incidence, the maximum occurrence of leakage. So be aware of that. In my solution, we have a follow-up which is continuing, and we are sure there is no doubt about the patient. a total security. I have a little experience for things some of you have already experienced. It's a patient 3 days after laparoscopic surgery, an in-bed procedure, morning visit, 8. The patient is not good, but it's not too bad. Well, feel a little bit anxious, little bit fever, no more. So I decided to wait. After a long day, I have my evening round, and the patient still exactly the same. Not too bad, but not better. A little less painful, but he had fever. But he's very warm in his room. He had vomiting, but when you see what is hitting, you say, oh, it's normal. No gas, no stool, but it's stay in his bed all the day. And his blood sample or limit. I have an explanation for everything, and I don't want to see the leakage. This is my subjectivity. The patient doesn't want to have a leak, and he say, no, I feel fine. The nurses don't want the patient to have a leak, so they say, no, it's not too bad. So what we decide, what I decide to wait. And of course, the day after, the patient had a peritonitis. On the other hand, the same patient with outpatient procedure. Data collected at 9 in the morning. All my items are low, mid, high, or accurate level alert. I have 3 mid-level alerts and 1 high-level alert. I build an algorithm. What says the algorithm in this case? The algorithm says up to 2 mid-level alerts or 1 high-level alert, patient should be considered to have a leak until proved otherwise. So the patient must coming back immediately, and I save 24 hours. How to do? This is not my keys of success. This is how I think we have to manage, not for outpatient, but for all ERAS program. If you want to try outpatient procedure, you have to be very, very huge experience in ERAS program and in outpatient surgery. Then you have to build a team project. You can't do anything alone with surgeon, anesthesiologist, and nurses. And then you have to build a specific institution protocol. It's your protocol. I have no one protocol. It's the only protocol you have to build. And then you have to adapt your follow-up for the patient with phone or digitally or mix. And then you have to try. And after each patient, you have to debrief everything to improve your skill. Well, I hope to convince you, and if you want to share, of course, we'll be very happy. Thank you very much for your attention.
Thank you.